specific learning disability, commonly known as dyslexia also. So since it is a very broad topic, I'll start the tutorial fast. Okay, so let's come to the first topic, that is autism spectrum disorder. Okay, so what is autism spectrum disorder? As you can, has anybody seen any case? Okay, maybe during COVID times you might not have seen any cases. If anybody had come to the department, they might have seen quite a few children who are presenting to us in the OPD with symptoms suggestive of autism spectrum disorder. So it is a constellation of early appearing deficits in social communication. So what do you mean by social communication? Communication, we all understand. It is the way you tell other person what you are thinking, and you also listen to what the other person wants to say. It is a usually two-way process. So when it is used for socialization, then it is what we mean by social communication. And the second part of this disorder, which is very important, is the deficits in problems with repetitive sensory motor behaviors. Now, this disorder has a very strong genetic component. In fact, in a study that was done in our department, almost 10% of the uh, families in whom there was one child with autism, there was another sibling who turned out to be having autism spectrum disorder. So this prevalence of 10% is in fact very high as compared to the prevalence amongst the community, almost 100 times. The second thing that we must understand, that autism spectrum disorder is a lifelong condition. So the support system have to be there for these children all through their lives. It is now a fairly common disorder. In fact, it's discussed very commonly in the print media, in the social media as well. The prevalence increasing very rapidly, and at present, even in India, it is supposed to be present in 1 in 100 children, and almost 1% prevalence, you can understand, is a very high prevalence. And this disorder, like other developmental disorders, is also much more common in males. So male is to female ratio being 4:1. In fact, some studies also say 5:1 also. So to understand this disorder, we'll go through the diagnostic criteria that will not only help us understand how to make the diagnosis, but it also clarifies the symptomatology. So if we come to the DSM-5 criteria for ASD, the first category is persistent deficits in social communication and social interaction across multiple contexts as manifested by the following, currently or by history. So it is important to understand that, one, the symptoms have to be present in multiple contexts. Secondly, these symptoms may change with time. Some symptoms may regress, or some may appear newly. So the presence of symptom is not essential at the time when you are assessing the child. It is not that you must have all the symptoms currently, but there may be some symptoms which may have been present in the past also. And if they are significant, they have to be taken into account when you are making the diagnosis. So under the domain of social communication and social interaction, the first area that you look at is social emotional reciprocity. Now, what do you mean by reciprocity? Everything which is two ways is reciprocal behavior. So here you have to look at social reciprocal behavior and emotional reciprocal behavior. So when you're looking at social reciprocal behavior, and all are this related to social communication. So social reciprocity would be, suppose when you are, say, you meet your friend in the corridor, how do you interact with that person? How do you start interaction? Normally what you will do is you will say hi, and you will wave your hand to say hello, and then the other person will also look at you, smile at you. So this smiling by with use of which you start a social interaction is known as social smile in the context, so socially responsive smiling. That is one component that is very commonly uh, deficient in these children with autism, or the even the adolescents and adults. So some children may not. So if the child has autism, and the other, if other person is trying to talk to him and gain his attention, this child may not smile back when you're trying to start interaction with him. Then there may be another other extreme of children with autism. Because it is a spectrum disorder, every symptom is on a spectrum from one end where it is totally absent to the other end when it is excessive. So for social smile also, you'll see that on one end you will have some children who do not smile at all when you are trying to talk to them or starting interaction with them. On to the other end, other extreme, wherein these children with autism may be smiling at each and every one person without any discrimination between people they know and or people they don't know. So, so this is one example of social reciprocal behavior which is abnormal. Then there may be these children under this, you will also see that they may not be interested in having friends. So they may have very what we call as socially aloof behavior in young children. They may not be interested in the other children. They will continue. So they may continue to have solitary play, not interested in playing with other kids beyond the age when they are supposed to be playing on their own. So I hope you know what is parallel play. So children normally till 2 years of age, around 2 years of age, you see that if a child, another 2-year-old child is playing with say drum. So suppose one 2-year-old child is playing with a drum, the other child also who's there, who's 2 years of age, would just pick up another drum and try to play on his or her own. So they may be doing the same play, but not it will not be a reciprocal play. They will not be playing together. So they will be playing parallelly with whatever toys they have. So this is normal behavior for children who have a mental age of around 2 years of age. Beyond this age, you will see that they will start gradually interacting. The play will become reciprocal. They will play with each other. So children with autism, even when their mental age is more than 2 years of mental age, they may not like to play with other children. So their play may be solitary, or they may, so their friends, they have a problems in making friends in that sense. The other aspect of social reciprocity that you look at is that when you are having conversation, suppose you go and start talking with your friend. How will you go about it? You will just smile at your friend. Then you understand that, okay, now suppose nowadays the serial Family Man is popular. Then you will start talking about Family Man to the other person. So both are at same page. You both will be talking about that same interest that you are liking. But a child with autism may not understand what is popular or what will be the interest of other people also with whom he's starting interaction. So if he is interested in railway timetable, he may just come in and start talking to other people, other children about railway timetables. So the topic and the interests are very, so he will not look at what other person is interested in. They do not understand what the other person is interested in. So the conversation does not have this to and fro quality. So if I ask you how was your day, or did you watch Family Man, then the other person will tell, yes, I saw this episode, it was very interesting, this is what happened. And then the conversation flows, it is in a two-way form, to and fro on the same topic. So children with autism, even though when they have a very highly developed language, may not be able to have this to and fro conversation. So they may keep on changing topics, so the speech or the talk or may become tangential. At one time they are talking about, say, family man, even if they start, in the next moment they will start talking about railways. At the other moment they may start talking about metro. So whatever is that, there is a problem in of tangential speech as well. So that is social reciprocity in conversation, which is impaired. Then social reciprocity also manifests as shared emotion. So what happens if you are, say, if you had gone to some, say, uh, hill station, and you come back and you are telling everybody excitedly that yes, I went on this trip and all, what do you expect your friends to do? You will expect that your friends will join in. They will be quite happy with you, will be as excited, or at least show some excitement in your happiness, join in your happiness. So this is emotional reciprocity. And and what will happen, suppose you're telling your friend about it, that yes, I enjoyed this and it was such a thrilling trip, and your friend does not reply back or does not show any interest. What will happen? Ultimately, gradually, your friendship with that person will gradually come down, and you may not no longer continue to be friends. Similarly, if you are upset, you expect the other person to have empathy, to share with you, to understand that you are upset. So emotional reciprocity is very important component of any social communication or social interaction. So children with autism not only share their interest, they may or may not share their emotional affect also, and may or may not understand to the extent that to the commiserate with their intelligence level other person's emotional state. So all these things create problems in their social interaction. Now coming to the second group, let's look at these other deficits. So the deficits in non-verbal communication behaviors used for social interaction. What do you mean? What do you mean by non-verbal communication? Verbal communication, everybody understands. Non-verbal communication is your eye contact, your facial expressions, your smiling, your body postures, your hand use, your gestures. All these things are what we call as non-verbal communication. Now, when we are looking at the symptoms of autism, under this domain, we are looking at non-verbal communication behaviors used for social interaction. So, for example, let us look at eye contact. What happens? Suppose you are one of your lecturer or your professor is coming or is there in the corridor. And if you like that professor or you want to start interaction with that person, what will you do? You will give good eye. You look at the person, give eye contact, smile at them or her or him, and wish them. Then only the interaction will start. What happens? On the other hand, if there is a professor or a senior whom you do not want to interact with, you don't like him or her and you want to avoid any interaction, what will you do at that time? You will not give any eye contact, you will look away and try to avoid any interaction. So, non-verbal communication behaviors become important even before you have started any interaction with the other person. So, so eye contact, social smiling. Similarly, body posture. Everybody would remember or would understand that. Suppose you're going to the head of the department for some favor. Even before you start talking to the HOD, by his or her body posture itself, you understand that the boss is in good mood or not, should and whether you should ask for that favor or not. So body posture and all these communication, non-verbal communication behaviors are very important for any social interaction. So children with autism may not have eye contact at all on one end, to the other extreme when they are making excessive eye contact with people. So poor eye contact means people will think that this person is not interested in what I'm talking about. In fact, many of them may get reprimanded by the teacher that they are not focusing in the class. On the other hand, if the child is having excessive eye contact, what will be the problem? If it is a boy, then it is even for girls, it is a problem. So if you are making excessive eye contact with another person, so if it is a girl and you are making excessive eye contact, then the girl may start thinking that you are this is inappropriate behavior. You're trying to start interaction when she is not interested. Similarly, for a boy, like so, eye contact itself may lead to lots of problems if it is not used appropriately. Similarly, social smiling, if your facial expressions, all these things are inappropriate. So suppose the child has been taken to a situation where there has been some death in the family, and the child starts going there. When the child reaches there, starts smiling at everybody, when everybody is crying and they are just laughing, then there is a problem. So in non-verbal communication behaviors, if they are inappropriate, they may lead to lots of problems in their day-to-day life. The third area, which is covered under deficits in social communication and social interactions, is obviously deficits in developing, maintaining, and understanding relationships. This is one feature which people commonly understand, that the children with autism are relatively aloof, they do not have friends. Now, again, we should understand that it is a spectrum disorder. On one hand, there may be children who are totally aloof. The parents themselves may start feeling that my child doesn't love me, or I am not able to take good care of my child. That is why the child has no affection for me. To the other extent, when this child is friendly with everybody, and that may become dangerous in today's circumstances or today's situation, when people can take undue advantage if the child is over friendly with anybody and everybody. So there are children who may have no friends, to the children who do not understand what friendship means. So if you ask a child who has autism, who or their parents, if you ask that, does your child have any friends? Many of them will tell you that yes, no, there is no problem with my child's friendship behaviors. He has got plenty of friends. But when you go into the deep depth of that friendship, they will tell you that yes, my child who say 8, 9 years of age has got many friends who are 15, 16 years of age. So when you ask them, have you watched them? What are they doing when they are in their friendship? So you'll find out that they'll tell you that yes, when these children are playing on the ground, say suppose they're playing cricket or football, the 8-year-old child with autism is just asked to stand on the boundary to catch the ball and give it to them. So this is again, or these people, the senior boys or girls will just keep on telling them what to do. So there again, the relationship is of a leader and a follower, where the normal children would become leaders and the child with autism will just be a follower. On the other hand, you may also have the situation wherein the child with autism makes friends with much younger children, wherein again the relationship is not two-way. The child with autism may become leader, and with very young children, he keeps telling them that this is what you have to do, and and the friendship is maintained only because young children or the other children are following or agreeing to whatever the child with autism is saying. So the basic concept of friendship is missing in these kind of relationships. The child with autism may also say that, yes, I am friends with one child in the class. And if you ask them what is their friendship all about, then again you will see that this two-way reciprocal relationship is missing, wherein the friendship was only related to one particular game that both of them like to play. Beyond that, there is no friendship at all. So that was the basic domain, that is first domain under which we have discussed till now, that there are persistent deficits in social communication and social interaction across multiple contexts. The second area that we look at is restricted repetitive patterns of behaviors, interests, or activities. And under this, want to assess the stereotyped or repetitive motor movements, use of objects, or speech. Now, this is another area which is very well known amongst general people about the children with autism. So one of these is that they use repetitive use or stereotype use of objects can manifest as repetitive lining of toy cars, blocks, uh, utensils. So this is very commonly seen. Then they may be looking at playing very stereotypically with some objects. So with cars, they may just be playing with the wheels of the car instead of playing with the car appropriately. So that is one example of repetitive use of object. Other can be that they are playing only with some say rubber band or some matchbox. So they are repetitive plays with objects. Then they may also have repetitive motor movements, and these are also, you may see that some children with autism may keep rocking back and forth, especially when they are upset. But otherwise, also many may be so happy with these repetitive movements that they forget where they are and forget what they were doing. So they get totally engrossed in that repetitive motor movements, for example, flicking of their hands repetitively, rocking back and forth, hand flapping, spinning around, going around in circles. So these are some examples of repetitive motor movements. And the third part of this criteria is repetitive speech. So this is what repetitive speech, when you're looking at, is one example is echolalia. That is echo, you all understand. Lalia is speech. So echolalic speech is repetition of the speech. So in this, if you I'll give you an example. If you ask the child, do you want ice cream? A child with autism may say yes, yes. He may not say yes. He may say you want ice cream, or he will just repeat ice cream. So when you say do you want ice cream, the child will say ice cream. So this is immediate equilibrium. So instead of saying that yes, I want ice cream, yeah, please give me ice cream, the child will just repeat ice cream. So this is immediate echolalia, or may also manifest as what we call as pronoun reversal, wherein when you say you want ice cream, instead of saying yes, I want ice cream, the child may say you want ice cream, meaning to say that yes, I want ice cream. So this is use of you instead of I. That is what is known as pronoun reversal. The child may also say that in case you asking, you want ice cream, the child may say, yes, Mohan wants ice cream. So he may or no use his or her name instead of using pronoun. So this is also a form of pronoun reversal. So we have taken some. I have explained few examples of what is stereotyped or repetitive speech. Now, apart from this, the second criteria under this domain is insistence on sameness, which may manifest as inflexible adherence to routines, ritualized patterns of verbal or non-verbal behavior. Now, this insistence on sameness is one of the reasons that these children may feel very anxious whenever they are going to a new place. So, and that may manifest as irritability, crying, and other behaviors when which these children manifest when they go to somebody house or to the OPDs. And also we should understand that these children want sameness in their life. Any change may or may not be acceptable to them. And again, you should remember that this is again on a spectrum. So let's take an example of, before we go to it, you should understand what is routine or rituals. So uh, the sameness may manifest even in ritualized behavior. Rituals is a sequence of behavior or motor manifestation or speech which is in a sequence form. So, for example, when you are talking about your religious rituals, normally there is a pattern. First, you have to do this, then you have to do that, then you have to do the third step. That is what is a ritual. So, in children with autism, may also, though it is not very common, they may develop some very specific rituals. Some may have, say, motor ritual in the form that one example would be that the child, when enters the room, has to first touch the door, then tap the wall twice, then switch on the fan, then sit on the table, and then go and lie down on the bed. Now, this is one example of ritualized behavior. If there is any change in this, if the child is not allowed to do this, even one step, and then child starts throwing a tantrum, then it is a problem. So this ritualized behavior can also be in the form of verbal behavior, verbal ritual. For example, a child would have a ritualized verbal behavior that as soon as he reaches home, his mother has to ask him, "How are you?" He will answer that I am well, and "How are you?" She also has to give a specific answer that yes, I'm well, I have cooked this for you. So if there is any change in that pattern, the child may start throwing tantrums. So this may create a problem. Now, coming to insistence on sameness, another example of this would be very commonly cited that the child is very rigid about the route that child is taking uh, to his school or his home. So, suppose the child has, if every day they are passing through the park to reach the school, and on any particular day, mother decides that no, I have to first go and buy milk from the mother dairy, then we'll go to school. And this simple change may again lead to tantrum to the extent that the whole routine is disrupted. So this is some example of insistence on sameness. The third category under this that is looked at is highly restricted fixated interests that are abnormal in intensity or focus. So some these interests may be what other children also do, or they may be very weird interests that no other child would be interested in. But this is very peculiar to this child with autism. So they may have, say, for example, interest in collecting some toffee wrappers. And if you look at it, the child would have hundreds and thousands of those toffee wrappers at his home, which he has collected. They are of no use otherwise. Then, or it may be that like other children who are interested in, say, or adults, suppose that everybody is nowadays interested in Family Man, for example, the child or person with autism may also be interested in Family Man, but then it becomes so excessive that nothing else is watched for months. Then it becomes abnormal. So this is one example of abnormal in intensity or focus as far as the interests are concerned. So many of these children are very interested in timetables. They may be interested in numbers, some alphabets. Some may be interested in some peculiar toy. There was a child who was interested in cooker pressure, so that they or chappals, footwears, and they will be going for footwears of every and any person in the uh, room. So they can be myriads of fixated interests, which would be considered abnormal only if they start affecting the functioning of the child and disrupting their routines and other activities. Then the last criteria under this is hypo or hyper reactivity to sensory inputs. Now, what are the sensory inputs that we are talking about? Here we are talking about for example, five senses: vision, hearing, touch, taste, smell, and say pain. So children with autism very commonly have problems related to pain. So some are so hypo-responsive to pain stimuli that they might have cut their fingers, would be bleeding profusely, but they are not aware of that pain at all. So it is not related to a neuropathy. It is just that their awareness or hypersensitivity to pain is there. On the other hand, there may be some children who would be crying excessively even to mild touch or mild pain, mild small injuries. So you have remember this disorder is on a spectrum as far as all the symptoms are concerned. So one is pain, similarly touch. Some children are so sensitive to any touch that leads to problems in what they are wearing. They are so aware of, say, tags on their clothes that they will not wear those clothes with any tag. They have to have very peculiar cloth material or texture. Only then they will wear it. Otherwise, they may not wear it. So that is hyperreactivity to touch. On the other hand, there would be children who like touch so much that they would keep touching, rubbing things, touching your hair, their hair, everybody, so that every touching excessively to get that sensory input to satisfy their body's need for touch. Similarly, there may be children who are hypersensitive to some smells. They will not enter the toilet or not enter even that corridor if they are very sensitive to even mild smells. Or there, on the other extent, there may be children who are not bothered by about any even excessive fulminant bad smells. So you have again excessive uh, variety of these symptoms. So one example, which is affect, which for example, a child who is a Bengal is a Bengali child, and in their family, cooking of fish is a essential part of their daily uh, life. But if child with autism is so sensitive to the smell of fish that the child will throw a tantrum or start vomiting and disrupt their daily life, then it becomes a problem. Similarly, visual symptoms are very common. Many of these children are relatively visual seekers, so they would be looking at lights on actual lights, or light being reflected from various surfaces, even mobile, toys, everything. If they are looking at that object and they are not focusing on the mobile as such, but or also on only on the light getting reflected from it, this is a problem. So some are visual seekers, others are avoiders. So you have a range of problems related to various senses. So it may be for the taste also, it may be related to pressure also, may be related to so pain, touch, smell, taste, and vision and hearing we have discussed. So some may be so sensitive to the sounds that they will not enter the marketplace, or they may not be people. Parents may not be able to take them on a public bus because of the sounds of the horn or other people is affecting the child very badly. So there are myriads of symptoms related to the sensory symptoms also. And if any two of these domains are or symptoms or criteria are positive, the B category criteria are supposed to be fulfilled. As far as A is concerned, all three deficits have to be there when you are considering the diagnosis of ASD. Now, once you have understood that this child is having problems, you're suspecting that this child has autism, you should also understand that commonly these children have other comorbid conditions as well. So amongst them is global developmental delay or intellectual disability, which may be seen in 70% of children. Apart from this, they may have behavior problems. I've talked about irritability or tantrums very often till now. Similarly, they may have, say, hyperactivity, which may manifest as psychiatric comorbidities in the form of ADHD. In older children, the insistence on sameness may lead to symptoms like OCD. Or when they are intelligent and they start understanding that they are different, they don't have friends, though they want to be friendly with people, they may start manifesting depression also. Apart from the psychiatric comorbidities and behavior abnormalities, epilepsy is common, in almost seen in 25% of these children, and the sleep problems are very common. Now, when to suspect autism? In young children, they are commonly brought as with symptoms of language delay or apparent deafness. Now, apparent deafness is manifest because they are not interested in that sound. So parents will very commonly say that when we call them specifically by their name, they do not pay any attention. But if some music which they like is being played in a different room also, then the child is able will run to that room. So their interest in because their interest in sound is variable and it is very fixated. This may lead to a diagnosis of some deafness, and most of them would be first going to a large chunk would first go to ENT people to get their hearing testing done because they think the child is deaf, and that is why the child is not listening, and that is why the child is not speaking. So this is second way in which they commonly present. Apart from this, young children commonly present with severe behavioral problems like excessive tantrums, hyperactivity I've already talked about. So when or some rigidities in peculiar behavior. So when you start suspecting that yes, you must rule out or check for symptoms of autism. In older children, because intellectual disability is common, so that itself may lead to poor school performance. And the other school performance because they do not understand the reason that they may have poor school abstract meaning of language being used. So they do not understand in day-to-day speech also that it was a satire. The people were pulling my leg instead of actually saying that yes, meaning to say that you are a very good boy. It was just a pulling of leg or being or bullying. They may not understand what is written in the textbooks also. So all these things may lead to poor school performance. Apart from this, they may present with ADHD-like symptoms. In young children, there are certain red flags which you must know when you should suspect ASD. So if any child is not having very good facial expressions, so no big smiles or joyful expressions by 6 months of age or thereafter, if there are no back and forth sharing of sounds, smiles, or facial expressions by 9 months, no babbling by 12 months, no back and forth gestures such as pointing, showing, reaching, or waving by 12 months, no words by 16 months, and no meaningful two-word phrases by 24 months. You must suspect that this child may be having a developmental problem, commonly autism. Now, the definitive diagnosis of ASD cannot be made by any investigation, say, for example, MRI or genetic testing itself. So, the diagnosis can do a detailed examination, including evaluation of their interaction and play before you make the diagnosis. Once you have made the clinical diagnosis of ASD, then you may need to do etiological evaluation also. So, testing for Rett syndrome is recommended in girls and Fragile X in boys. These are genetic tests. Then, because deafness or apparent deafness is a problem and language delay is a symptom, you must do hearing screening in all children who present with ASD, especially those who are coming with language delay. Now, MRI does not give you the diagnosis. In fact, it is normal in majority of children with autism. However, if the child with autism has microcephaly or there are neurocutaneous markers or there is an abnormal neurological examination or there is history of regression, you must do neuroimaging in these children with autism as well. Now, if the child with autism has any dysmorphology or has a very strong family history of autism, then genetic testing in the form of exome sequencing or ADCGH may help in further planning of the uh, child management. Now, coming to the management, the symptoms or core symptoms can be managed only by behavior strategies. You must understand, and as a physician or a doctor, you must, when the parents come to you, you must tell them that please don't go in for harmful strategies because on Google, people are advertising about some strategies like chelation therapy and hyperbaric oxygen. And you must inform them that these are harmful things and they do not benefit the child at all and should be avoided. Apart from this, you can give some drugs for management of maladaptive behaviors like hyperactivity. The child is having marked aggression or self-injurious behaviors, then you may need to give some medicines also. Now, coming to the specific second disorder, which is specific learning disorder. Now, specific learning disorder is a developmental disorder which is related to the learning. So, this disorder is usually recognized only after the child starts going to school. And what are the areas which are affected by this? It is related to the reading skills, comprehension of the written or verbal language, written expression and spelling, and mathematics. So if a child is good in English, Hindi, and maths, but is having problems in, say, social sciences or sciences, then it is not specific learning disorder. So children with specific learning disorder must have problems in the medium in which the child is being taught. That is either English, Hindi, or say French, or whatever is the language in which they are being taught, or mathematics. In these children, their academic achievement would be much lower than expected. So usually the parents or teachers will say, otherwise the child is very smart. He or she is very good at so many other things, very smart, very intelligent. But when it comes to studies, they are not interested. They do not want to study, and therefore they are performing very badly in the schools or in their exams. So when you're thinking of poor school performance, what are the other things you must rule out? So the child should not have any intellectual disability, because if your cognition is impaired, then obviously your school performance will not be good. Then to learn, you all understand that if the parents are uneducated, if at home there is a lot of fights or other problems at home, if the child is coming from a very poor background where there is no food also available, what to think of buying books and all, it will be a problem for the child to learn. Then if the child is going to school where there are no teachers, or teacher is not teaching them properly, then also the child's performance would be affected. A child who has vision or hearing problem is not able to see what is written on the blackboard properly, or is not able to hear everything the teacher is saying clearly, then obviously his learning would be affected. Apart from these, you must rule out organic conditions like a child who's had pediatric stroke or a motor disorder, so he's got problem with his grip and other things, so he may, or clumsiness is there, so this may also affect the child's school performance. Now, the diagnosis of this condition is also again by clinical evaluation. So one is you'll take history of medical and family history to understand if there is anything else which is causing the learning problems. The other thing which is very important is because it is related to problems in learning, you will obviously look at the school reports, the educational and psychological assessments of the child, and there are standardized tests available to assess whether the child's learning skills are commensurate with others of his or her age or not. So there are these standardized tests. For example, include Woodcock Johnson test, the Indian test being NIMHANS index, or what we known as grade level assessment device. So these would look at the child performance. So suppose the child is in class 1, the battery would be assessing class 1's English, Hindi, or Marathi. So you have standards of learning, specify them, example, or word or fluency is affected. So some children may be able to say, suppose it is written hat. So the child may be able to say hat. So he will be able to say hat, that, bat, but when they are trying to read it, there is so much problem related to reading that if they are able to read also, they do not comprehend what is written. So they may read hat, bat, but they do not know what is the meaning of hat and what is the meaning of bat. So that is what is reading comprehension. So dyslexia is the commonly used term for those who are having impairment in reading. Similarly, there are children who have impairment in written expression. So here we are not talking about handwriting skills. Here we are talking about spelling accuracy. So they commonly make mistakes in spelling, even after they have tried to learn them very strictly. Still, they will have problems with spelling. They will have problems with grammar, punctuation, where it is capital, where it is not to be, where it is not to use capital. So all those problems will be there. In older children, they do not understand how to, suppose you ask them to write about my father, how to start the essay on on his or her father, what to talk about it, how to write it, all this, and their clarity and organization of this written expression may also be affected. So this is what is known as commonly as dysgraphia. And the last is impairment in mathematics, where they will have problems with the number sense, memorization of arithmetic facts like multiplication tables, accurate or fluent calculation, and accurate math reasoning. This is what is known as dyscalculia. Now, the treatment of this disorder is not with any medication, it is by remedial education, and the special education teachers develop an individualized program for each child, targeting the specific deficits of that child, so that the child can, if we doesn't know how, if the child cannot learn the way we are teaching, we have to modify our teaching program so that the child learns. Now, the last disorder that I want to cover is attention deficit hyperactivity disorder, and this is exhibited by persistent age inappropriate symptoms of inattention, hyperactivity, and impulsivity, and they are supposed to be causing significant impairment in major life activities. Now, the key symptoms of this disorder fall under two well-documented categories. First is inattention domain, and second is hyperactivity and impulsivity. So, hyperactivity, impulsivity commonly go hand in hand. Now, coming to the predominantly hyperactive impulsive type of ADHD or presentation of ADHD, these children are quite hyperactive. They cannot sit at one place for long. So this will be not only in the classroom. If the parents would remember that when they used to take the child to even movie theater, where other children would be very happy sitting and watching the movie, this child will not be able to sit for long. He has to get up and go out of or walk around, jump around. They may try to go out of the movie hall. So the hyperactivity would be manifest in various situations. In classroom also, a child with hyperactivity, you will suddenly see that when teacher is taking class, suddenly the child gets up and goes to somebody else's desk. And if the teacher points out, why did you get up from your seat? They may come up with very lame excuses that, ma'am, I wanted rubber, or I had left my pencil over there. Sometimes they make excuses that I want to go to the washroom. So they have to get up. It's very difficult for them to sit at one place for long. This hyperactivity may also manifest as something called fidgetiness, that they cannot sit still. Even if they are not getting up and walking out of the or out around in the classroom or the places, their restlessness is manifest, that they will be twirling their pencil, touching page, flicking page, touching this thing or that thing. So they're all the time moving, and which is what is known as fidgetiness. This may also manifest as excessive running and climbing. So parents may come and tell you that my child is so active, it is as if a motor has been fit in their body and they keep running here and there. The second domain, which is part of this symptom domain, is impulsivity. So these children may have difficulty in waiting for their turn, not only say in the classroom, but also in the community at large. So they may suddenly blurt out answers, they may interrupt conversations, and suppose they are, especially say they are adolescent, they are so impulsive, they may indulge in risky behaviors, and this may manifest, they say suddenly they may start smoking. If somebody says that, do you want to try a particular drug? I'm talking about abusive drug. So instead of thinking about, they will impulsively start taking or taste it. Similarly, they may start smoking also. So all these are risky behaviors in which these children or adolescents or adults may suddenly indulge in, and this is another area that we must look for. So impulsivity would manifest in, suppose the parents are talking at home and it is an adult type of discussion that they are having. Suddenly the child will just butt it. Similarly, in the class, if the teacher is asking question, even before the teacher has completed the sentence or the question, the child may suddenly raise his or her hands and suddenly blurt out the answer. Many a times it may not be even the right answer. So impulsivity, hyperactive impulse behaviors, they are quite common and very common presentation and very obvious to people. The other is predominantly inattentive presentation. Now, this is something which is very subtle. They may not be very obvious to people around that these children are having problems, and so commonly go unnoticed. So these children have difficulty in sustaining attention. They are forgetful in their daily tasks. So they might have completed their homework, but the child has just forgotten to bring the homework, and so they get reprimanded for making silly excuses for having not done the homework at home. Or they may have problems organizing tasks. So the child does not know how to pack things for his school. If they have an arts class, what all equipment or material he or she is supposed to bring into the school. So this problem in organizing tasks may continue even as adolescent or as adults. So when they're planning various activities, these skills may be deficient as compared to what is expected at that particular age. They may also get easily distracted by extraneous stimuli. So suppose a class is going on, everybody is focusing in on what the maths teacher is teaching at that particular time. But then there comes a bird who starts chirping. Others would be still focused on what the teacher is saying. But a child with ADHD who's having inattentive type of presentation will suddenly forget what teacher is saying and their attention will be totally focused on that bird. Now, if you miss even one or two steps of a math sum, you can understand that you will not be able to solve that problem later at all. So these children would commonly present with poor school performance because of their inattention. So there is one group which presents with hyperactivity, impulsivity. There is another which may have just inattention, but commonly there are features of both hyperactivity, impulsivity, and inattention when it is known as combined presentation of ADHD. Now, overall, ADHD is very commonly seen in schools. The prevalence may be as high as 18%, but commonly the teacher will say that in a class of 45, 50 children, there would be around 4 5 children who would have these symptoms. Till now, these children would be just get a label that they are Sharati kids, they are naughty boys and girls, or otherwise, then they have actually a problem. So it is very important to make these diagnoses so that these children do not get reprimanded for something which is not in their hands and can be helped with by medications and other interventions. This disorder again is more common in males, with the ratio being almost 4:1 or 2:1 for predominantly inattentive type. They not Many children with ADHD would also not have other conditions like autism. We have already talked about it. So ASD, specific learning disorder, or ODD are other symptoms which or disorders which are commonly associated with children who are having ADHD. Now, diagnosis is again a clinical diagnosis. You look at the symptoms, they should be present in multiple situations and should manifest before 12 years of age and should be significant enough to affect their social, academic, or occupational functioning. The management is not only with behavioral intervention, but for ADHD, medications and educational intervention make a big difference. So the medications are generally given to children who are more than 6 years of age and adolescents or older children. While for younger children, behavior therapy is the main mode of management because the side effects of medication may be quite significant in this age group. So pharmacological intervention is in the form of either stimulants, wherein you have say methylphenidate or lisdexamfetamine or mixed salt amphetamine. You have long sustained release or medications or formulations of methylphenidate also available. which have helped made the management quite easy, better for these children. The second group of medication is non-stimulants like atomoxetine. Uh, and both these drugs have major side effects in the form of loss of appetite. So if you are being given these medications for long, the growth has to be monitored very carefully. Methylphenidate may also have cardiac side effects. So that before you start methylphenidate, the blood pressures or family history of cardiac involvement has to be taken. So if there are no other questions or no other queries, we will end this. Yeah. So the personality disorder, like somebody has asked about the difference between ASD and schizoid personality disorder. Personality disorders are usually it's a diagnosis which is made in older children, not children, adolescents and adult life, whereas ASD is manifest in early childhood. And personality disorders usually do not manifest in, say, developmental delay and other problems. So yes, you can differentiate between the two. Then Shiva has also asked, how do the medications help in ADHD? Okay, so in ADHD, there is basically a imbalance in the neurotransmitters, the dopamine level specifically. So when you give these medications, the imbalance in the neurotransmitter is taken care of. In the specific areas, some specific areas of brain which are involved in the attention and activity control. So that is how these medications help these children. Okay, Shreya has asked, is there a reason why the incidence of ASD and ADHD is increasing in children? Or is it just that they are being detected more now? Okay, this is a very important question. One of the reasons why these diagnoses are being made more often is obviously because the people are now more aware, the pediatricians or the psychiatrists are more aware of these conditions now. Even general public is much more aware of these conditions. So there were times when children with autism would get just a diagnosis of mental retardation, wherein now you know that okay, this is not simple mental retardation, the child has autism also. So one is the problem with the one is that their labeling is being get or diagnosis is being made more correctly. The second is that the criteria have become more broad, and so the diagnosis is again increasing. And the third plausible reason is that yes, the actual incidence or prevalence of ASD and ADHD might be increasing uh, for which there may be many reasons. Uh, so I think that would have answered your questions. Okay. So if there are no other questions, I will end this session. Thank you for listening so patiently. How do you end? End it.